Okay, it looks like it's 12 o'clock and folks are joining en masse, so we'll get started. Hello, everyone. Welcome to Department of Medicine Grand Rounds. My name is Celia Hayring. For those of you who don't know me, I'm one of the UW-Montlake Inpatient Internal Medicine Chief Residents. As a reminder, throughout today's Grand Rounds, you may all submit any questions that you're having through the chat function. I'll be collecting those questions and sort of moderating them for our speaker at the end of the talk. And now to introduce the Samson visiting lecturer and today's speaker will be Dr. Jordan Prutkin from the Division of Cardiology, the current interim division head.
Great. Thanks, Celia, and thank you everyone for coming today. I want to start by thanking Joan and Werner Simpson for supporting Dr. Fonarow's visit these last 2 days. I don't know if who knows Dr. Simpson or those who don't know Dr. Simpson. So Robert Bruce was hired in the 1950s to start the Division of Cardiology at UW, and this is Dr. Bruce created the Bruce protocol for stress tests. And at that time, he hired Leonard Cobb and Werner Simpson and a bunch of other people who we don't actually know who they are in the picture, and Dr. Sampson couldn't quite recall. And Dr. Samson was the dean of admissions here at UW for many decades, and is a cardiologist here whose patients loved him as much as I've ever seen patients love someone. He retired a few years ago. This is him with his wife, Joan. This year's Samson professor is Dr. Gregg Fonarow from UCLA. Gregg is a heart failure cardiologist, and he's had many roles throughout his career. He was fellowship director. He's the director of the Ahmanson-UCLA Cardiomyopathy Center. He's co-director of UCLA's Preventative Cardiology program. He's currently the interim chief of cardiology at UCLA, and he's been doing it for 4 years. And as I looked through his 379-page CV, which really doesn't have a lot of filler there, so much of his career has been focused on quality, performance, systems of care in cardiology, with this focus on heart failure. He's received numerous American Heart Association and American College of Cardiology awards. He's been on a plethora of guideline documents. He has 1,540 peer-reviewed papers with 76 editorials, 166 review articles. That is enough for many people's careers in that. And it's also really just a strong reflection of the number of trainees and collaborators that he's worked with throughout the years. So we are very excited to have Dr. Fonarow here with us as the Joan and Werner Sampson visiting professor this year. Thanks so much for coming, Gregg, and I will stop sharing my screen.
So thank you so much for that really kind and generous introduction. It was a pleasure to meet Dr. Samson, an honor to be part of this named lectureship, and I've really enjoyed my time here. And I really look forward to presenting this topic. I'm really passionate about improving the quality of care and outcomes for patients with heart failure. So with that in mind, here are my disclosures related to the presentation, and please keep those in mind. For background, this slide illustrates really the significant impact that heart failure has. There are currently 6.7 million men and women with the United States. There'll be over 1 million individuals that newly develop heart failure this year. The mortality rate, astoundingly high, 415,000 deaths a year. That's approximately 35 to 40% of the cardiovascular deaths. Hospital discharges, 1.3 million with a primary discharge diagnosis, another 3 million more heart failure as a secondary diagnosis, and with tremendous costs. So we've got something that's common, costly, and by natural history, deadly. As I'll show you, we have a number of therapeutic advances, but despite this and despite guidelines, there's still a large number of eligible patients that for a variety of reasons are not receiving one or more of these evidence-based life-prolonging guideline-recommended heart failure therapies, and as a result, having hospitalizations or cardiovascular deaths that potentially could have been prevented. And so I hope to impress upon you and show data that supports that greater therapeutic urgency for heart failure is needed. So here's data we generated from Get With The Guidelines linked to Medicare. So it's individuals age 65 or older who develop heart failure and looking at their median survival. And you can see across the EF spectrum, survivals in the sort of depending on the age group, 3.3 years, 4 years, those above 90, 0.8. If we compare that to the life expectancy of those without heart failure in the US of similar age groups, we see that heart failure development is associated with, a greater than 15-year loss of median survival for those aged 65 to 69. Even for those above age 90 developing heart failure, it's 4 years of loss of life. So what can we do to improve upon this natural history and these very poor median survival to give meaningful and quality life back to these patients? Now, fortunately, through remarkable discovery science, a number of therapies have been developed based on physiologic rationale and experimental data, and then ultimately tested in randomized clinical trials, and showing they have the ability to not just make patients feel better, not just naturally alter or reduce the risk of being hospitalized or rehospitalized, but having the actual power and ability to lower all-cause mortality. You can see the relative risk reductions with these therapies in mortality. And in absolute terms, the number needed to treat to save a life standardized over 36 months. So we really have these remarkable therapies, and some even with single-digit NNTs for survival, not just events. And many of these therapies also lower the risk of hospitalization or rehospitalization. So we have a number of evidence-based tools that can meaningfully improve outcome. So we would imagine as these therapies became available, recommended in the guidelines, and then presumptively then applied by clinicians into practice, should now be able to show you how nationally for patients with heart failure in the community across the country, outcomes have been steadily improving. But what we see in the US and even across the world is pretty surprising. When we look at the time these therapies became available and integrated in guidelines, maybe on the trend line, you can see a little improvement in 1-year survival, 5-year survival, 10-year survival, but not a lot of change. And the mortality risk in these time periods remains substantially high. So despite availability of therapies with well-established efficacy and recommendations in the guidelines for heart failure with reduced EF, morbidity and mortality rates remain high. Now, how can we explain this, that the therapies actually don't translate to clinical benefit in real-world patients, or is something else going on? But when we look in a variety of settings to try and explain this seemingly paradoxical association, we get data like this. This is from the CHAMP-HF registry. This was 150 primary care and cardiology practices across the country, 3,518 heart failure reduced EF, clinician knew they had heart failure, patient knew they had heart failure, any patient with contraindication intolerance excluded from the denominator. And what we see here is, well, there is some medication use. About 2/3 are receiving an ACE inhibitor ARB and about 2/3 a beta blocker. But for other therapies that were class 1 recommended guidelines, such as sacubitril/valsartan, the angiotensin receptor neprilysin inhibitor, in a time frame that it was already class 1 recommended in the guidelines as life prolonging, only 13% of eligible patients treated. MRAs, where we've had data for over 2 decades of them reducing mortality 26 to 30%, only 1/3 of perfectly eligible patients. And then in looking at dosing, the vast majority of patients were on medications that were supposed to be, according to the guidelines, titrated up to a target dose so long as well tolerated. Most patients were on, lower doses, despite not a clear reason why they weren't up titrated. And when we asked for a simple question about triple therapy of these 3 classes, how many were simultaneously treated and treated target dose, it was only 1% of patients. So we see that, there are these very large gaps. And you say, well, maybe we just were unlucky here with the practices and clinicians that were selected, but data in all the settings outside of highly specialized heart failure centers show this exact same thing. Gaps in use, gaps in dosing. This is data now generated from 724 outpatient U.S. practices participating in the Pinnacle Registry from the ACC, 6 million outpatient heart failure visits, heart failure reduced EF eligible patients, again, no contraindications or intolerance. And again, with similar type of data on the use of ACE inhibitor ARBs and beta blockers, about 2/3 of patients, maybe a little improvement over time, but use of sacubitril valsartan less than 10%, MRA 25%, and still even for beta blockers, ACE inhibitor ARBs available generically, these treatment gaps that are difficult to explain. So what is behind the reason for underutilization of truly evidence-based, but not just evidence-based, recommended to reduce all-cause mortality in the patient population? So this may be gaps in knowledge and awareness, just not aware of the trials or the actual guideline recommendations, and perhaps education could help. But more likely, this is the lack of systems that at the individual level and global systems not in place to ensure that eligible patients are identified, appropriately treated, and adhering to therapy. And we'll get into whether there's evidence that deploying systems can improve use. There is also very strong therapeutic inertia and insufficient sense of urgency, that the level of risk during outpatient visits is not adequately perceived, and feeling, well, the patient is doing reasonably well. Is it worth rocking the boat and starting additional therapy or up titrating? There may be questions about, well, the randomized trials, in those patients it worked, but, my patient's older, more complex, more comorbidities, too narrow in scope in the trial, so I'm uncertain regarding the real world effectiveness. Concerns about side effects, adverse events, safety. So, do the benefits truly outweigh the potential risks? Could some of this reflect bias, based on the patient's age, sex, race, ethnicity, socioeconomic status, where a physician perception is influencing whether that therapy is prescribed? And there's a lot of evidence to support that. So overcoming this systematic bias will be important. And then concerns about access, cost, prior authorizations, cost effectiveness, and value. So as we think about what are some of the ways we can overcome the underutilization, we'll need to address these various concerns, and how convinced are we that these are really legitimate and what's happening? So here's data to look at this concept of therapeutic inertia. So we followed patients longitudinally over time in the CHAMP-HF registry to say, well, okay, at baseline, you weren't necessarily on the guideline recommended therapy, but certainly through continuous follow-up through 12 months with visit after visit, we would expect to see initiation and up titration. But we didn't see that at all for every class of med, whether generic or branded, whether a patient seemingly had worsened symptoms, whether the patient had an intervening hospitalization. That level of risk that they faced didn't seem to warrant adjustments in therapy visit after visit. Now, some of the notes would say, plan to, we'll think about a next visit. So entering the clinician's mind, but not enough to cross the threshold to actually make a meaningful change. And so patients, in the absence of documented contraindication and tolerance, had no improvement, no escalation or guideline-directed medical therapy each and every visit that occurred during 12 months of outpatient follow-up. That was characterizing the vast majority of patients that were followed over time here. So what about perception of risk? Well, in our terminology, often people would refer to chronic stable outpatients with heart failure, with, not having a recent hospitalization, as if maybe their therapy didn't need to be escalated. But if we look and compare to atherosclerotic cardiovascular disease and the terms used to define the annual risk rates for those at intermediate or high risk or very high risk in the guidelines for those with coronary disease, and look at those fatal and non-fatal event rates and compare them to heart failure patients in the lowest risk category, these patients are, nowhere near as low a risk as the highest risk of ASCVD. So should be referring these patients as extreme high risk to convey the urgency, and those with a hospitalization or advanced heart failure in the very extreme high risk. So this current generalized lack of therapeutic urgency seems to translate to this unfortunate cycle where clinical risk is underappreciated, medication changes don't take place at every opportunity, but are deferred, thus time is lavished, and patients may have events that could have been prevented had those therapies been initiated in a timely fashion. Now, the other thing we see in the patterns of heart failure therapy is patients are often on one or two of the medications, but triple therapy, quadruple therapy, far more rare. So does this reflect physicians feeling like, well, if I got one or two therapies on board, maybe additional therapies are somehow redundant or only partially additive, that I'm diminishing returns, or maybe even subtractive and would undo benefit? And that seems to be what's reflective in how these therapies are being used, at least in part. So is there compelling data that these therapies are truly and fully additive to each other, that they're non-overlapping mechanisms, and that the benefits are truly additive, cumulative, incremental, and thus worth using the full contingent of foundational evidence-based therapy for heart failure? So spend a little bit of time showing you how the clinical trial evidence really does strongly support this. So original mortality reducing trial with ACE inhibitors, and you can see the magnitude of risk reduction seen here, averaging approximately 17% overall, but the power to improve survival when ACE inhibitors were added to a background of loop diuretics. Then in the beta blocker trials, they were added on top of ACE inhibitor ARB. And what you can see is this incremental, truly cumulative, additive survival benefit on the order of 34 to 35% relative risk reduction mortality, and replicated across 4 major randomized controlled trials, and benefits across all of the clinically relevant subgroups. So clear evidence, double therapy better than single therapy, and 1 + 1 clearly equal to, if not more. How about aldosterone antagonists, so MRAs? When first studying the RAWS trial, there wasn't a lot of background beta blocker use. Those trials were just being undertaken, and there was a large mortality reduction, though, added to ACE inhibitor ARB. But in emphasis now, high background beta blocker use in more mild heart failure, ACE inhibitor ARB use high, adding MRA, clear reduction in all-cause mortality. So 1 + 1 equaling 3, triple therapy, clearly better than double therapy, and truly additive and incremental benefit. Now, the next therapy tested was that of neprilysin inhibition with sacubitril, but needed to be combined with an ARB, so looking at angiotensin receptor neprilysin inhibitor, and thus wouldn't be fair to compare to placebo, was instead compared to a gold standard ACE inhibitor, enalapril. But now looking at the addition of neprilysin inhibition on a high background rate of MRA and beta blocker in every patient, either ACE inhibitor or by sacubitril, valsartan, the valsartan ARB. And what we see is an incremental additive benefit here, CV death, all-cause mortality. So we could further improve outcome with an additional mechanism of action, neprilysin inhibition. So clearly incremental benefit. To highlight that, compared to an ARB or ACE inhibitor, we could double the mortality reduction with the addition of neprilysin inhibition instead of ACE inhibitor ARB, using that combination of angiotensin receptor neprilysin inhibition. Now, importantly, was this the entire patient population, or were there selective patients that would be better off on an ACE inhibitor? And what we see here across 64 clinically relevant subgroups for the primary endpoint and for CV death, no significant interaction or heterogeneity, and a population-wide benefit. If you had heart failure with reduced EF, you were better off on sacubitril valsartan than the ACE inhibitor enalapril. And there's similar data for beta blockers and similar data that exists for MRAs. So truly this population approach, rather than trying to selectively apply the therapy only to certain patients with heart failure reduced EF, seems to win out. Now, the next class of therapy, really discovered by serendipity, the SGLT2 inhibitors being studied for cardiovascular safety in those with type 2 diabetes. And the EMPA-REG outcome study had this remarkable finding that there was a reduction in cardiovascular death, and 70% reduction in heart failure death, less heart failure hospitalizations, which wasn't even an endpoint in the trial, was there for safety. And yet in other type 2 diabetes trials rapidly integrated heart failure as an endpoint and were able to show this was a consistent finding, and raising the possibility that this may not just be a treatment for heart failure, but for our type 2 diabetes, but a treatment for heart failure even in those with the absence of diabetes. And so you can hypothesize a whole variety of mechanisms, but clinical trialists rapidly took this finding from EPIREG outcome and designed this trial, DAP-HF, 4,744 patients with heart failure reduced EF on standard background therapy at the time, primary endpoint with or without diabetes, and randomized straight up to dapagliflozin versus placebo. 55% of these patients did not have type 2 diabetes. And what we see for the primary endpoint on good background therapy, including sacubitril/valsartan in some of the patients, high use of beta blockers, MRA, this incremental benefit very early on continuing to separate, NNT of 21, relative risk reduction 26, highly statistically significant. Was the benefit just combined to those with heart failure plus type 2 diabetes? No. Those without type 2 diabetes driving every bit as large a benefit. So now an incremental benefit, and now we've entered the era of quadruple foundational therapy for heart failure with reduced ejection fraction. Is this a population-wide benefit? It was, regardless of age, gender, race, ethnicity, region of the world, etiology for heart failure, body mass index, GFR, New York heart class, and terminal BNP, comorbidities. You saw incremental benefit. Regardless of what background medical therapy you were on, the additive benefit, including on a background of sacubitril/valsartan, is additive benefit. What about safety and tolerability? There was those without type 2 diabetes, no hypoglycemia, no diabetic ketoacidosis, and other things overall for treatment adverse events. If anything, drug was better tolerated than placebo. So serious adverse events, if anything, lower. Could this be replicated? Here's EMPEROR reduced and DAP-HF combined in meta-analysis, and you can see cardiovascular events, but also importantly, all-cause mortality significantly reduced, and the benefits across all clinically relevant subgroups with or without type 2 diabetes. So truly an evidence-based regimen for mortality for all four of the major classes. So we see the cumulative impact here in the natural history of heart failure with reduced EF. About 1 in 3 patients have mortality within 2 years, 35%. We look at then the incremental benefits, ACE inhibitor ARB, 27% mortality would reduce. More beta blocker can get this down to 18. Aldosterone antagonist 13. Replacing ACE inhibitor ARB with sacubitril/valsartan now down to 10.9 in the SGLT2 inhibitor. The additional relative risk reduction of 17% and down now to 9.1. So together, that quadruple therapy can give us a relative risk reduction in all-cause mortality at 2 years, 74%, an absolute risk reduction of 26%. 26 per 100 additional lives saved, and the number needed to treat to save a life over a 2-year duration of less than 4. So phenomenal benefits, unrivaled in what we can accomplish in cardiovascular medicine. So the question then becomes, okay, so we've got the data evidence, the guidelines give this class 1 recommendation, the magnitude of cumulative benefit is very large. How should we go about implementing in clinical practice? So some have advocated, and have just kind of followed by default, well, we'll just follow the sequence in which they were discovered and applied in clinical trials. But if you really begin to think about that, we'll start first with an ACE inhibitor ARB and then up titrate and then add the beta blocker, and then once on target dose, add the aldosterone antagonist, and once on dose there, then switch over to sacubitril/valsartan, and then once that's up titrated and optimized, then add the SGLT2 inhibitor. What would that actually take to accomplish, and do we have the time, and is that really the best approach? So if we actually map out this historic sequence of GDMT in a serial strategy, you begin to realize, wow, there's quite a bit of time going on here. Even if having every 2 to 4 weeks titration taking place and doing this without fail, and the patient follows up on each of these and the steps are taken, we would map this out to 28 to 56 weeks till GDMT has been initiated, titrated, and fully implemented. So do we have the time? Are these therapies so slowly acting that it doesn't really matter how quickly we face it? And then if we think about it a little bit, how many people are having their drugs titrated remotely, or is this requiring a visit back face-to-face? And how many heart failure patients really have follow-up visits every 2 weeks, and this go on serially? So if we now make that duration, 2 or 3 months between visits, now we're talking 3 or 4 years till GDMT is fully implemented. So you begin to realize, wait, there must be people following this, because we see it 12 months, 24 months, 36 months, vast majority of patients not on optimized GDMT, and perhaps clinical inertia takes over. But, that's an assertive amount of time that everybody would agree with doesn't make sense. So, do we have the time as well to wait that long? So this question of timing of GDMT benefits. And what's been underappreciated, because many of these trials looked at chronic stable outpatients being initiated on therapy, is how incredibly rapid the benefits are seen. This data, Copernicus, evidence-based beta blocker, carvedilol, severe heart failure, within 2 weeks, the survival curves have diverged. Worsening risk of heart failure much higher if deferring the beta blocker rather than starting it. And so we see this very rapid benefits. What about with MRAs? Within 19 days, statistically significant reduction in cardiovascular death, heart failure, hospitalization, highly significant by day 30, and a benefit over the course of the trial. So we see very early and substantial benefit here. Pioneer-HF actually did test sacubitril/valsartan versus enalapril in the hospital setting. In Paradigm-HF, the trial I showed you before, outpatient setting, there was clear benefit within 30 days. But here in the hospital setting, starting the ACE inhibitor versus starting sacubitril/valsartan in hospital, the event curves diverged very quickly, highly significant by 30 days over through 8 weeks, a 42% relative risk reduction, a 6% absolute risk reduction in CV death, heart failure, hospitalization, tremendous benefit. This was true whether de novo heart failure, so the first time the patient was seeing any RAS inhibitor, or worsening of chronic heart failure where you may have been switched over from an ACE inhibitor in the sacubitril/valsartan arm versus continued on the ACE inhibitor. And so we clearly see benefits regardless of whether patients are presenting with new onset heart failure or worsening of chronic heart failure. Importantly, you could say, well, what's the problem of delaying 8 weeks and then switching over? But this illustrates it, because in the trial, you couldn't have followed patients beyond 8 weeks because the guidelines already recommended sacubitril/valsartan. So at 8 weeks, everybody was on sacubitril/valsartan. And what you can see is the curves may alter a little bit in the enalapril arm, but you never got back to catching up. And so events occurred that you couldn't get back. And so delaying initiation of sacubitril/valsartan by 8 weeks led to preventable events, never caught up, and ultimately highlighting how delaying therapies, even for a few weeks, can lead to consequences of events that otherwise could have been prevented. SGLT2 inhibitors, the timing are remarkable. In DAPA-HF, within a day, you could see a lower hazard ratio. It was statistically significant by day 28 and never crossed over again. In hospital initiation in the SOLACE acute heart failure trial, with sotagliflozin, you had a clear benefit within 30 days, statistical significance. And Impulse trial actually randomizing to SGLT2 inhibitor versus placebo in the first 24 hours of being hospitalized with acute heart failure, and there was clinical benefit seen, and even quality of life. First time you assess it at 2 or 4 weeks, you are already seeing improvement. So very rapid timing and benefit. So putting this all together, we have proposed, and this is published in JAMA Cardiology, now endorsed in many ways in the guidelines, of a focus on rapid intensive initiation of guideline-directed medical therapy focused on the mortality-reducing foundational therapies that are class 1 in the guidelines, and with the ability at the low recommended starting dose in patients that are stabilized and without cardiogenic shock of initiating all 4 at low dose simultaneously. If for a given reason don't want to go exactly simultaneously in a very rapid sequence, over a day or 2 or 3 or 4, but no longer than that. Can then up-titrate. The beta blocker is the priority, then back up on day 14 and 28. The sacubitril/valsartan, the MRA is adjusted as by potassium. SGLT2s, no titration necessary, single dose, no up-titration. And with this approach, by day 21 can be on fully optimized, well-tolerated target dose of the full set of guideline-directed medical therapy. Then can focus on comorbid conditions, additional therapies that may be necessary. But in doing this, it would be estimated within that first 30 days, a greater than 75% reduction in cardiovascular death or heart failure hospitalization. So that is the approach that was recommended. Beyond the benefits on clinical events, there's a rapid improvement in health status, rapid improvement in LVEF for 30-day rehospitalization metrics that are publicly reported and hospitals penalized, can markedly improve that, and can, by starting in the hospital, taking advantage of the teachable moment, improve use, adherence, and persistence of these meds. And most importantly, if you're treated right away, there isn't that inertia to overcome. You're already on the full set of meds and can just be focusing on titration rather than having it drawn out or weeks or months where inertia takes over. Now, since we first proposed this, there have been alternatives suggested, but the key point here, whether going 2 by 2, 3 by 1, all sequential, or any other version of this, that they're all focused on rapid initiation and up-titration of GDMT as the foundation of therapy for heart failure with reduced ejection fraction. There is modeling done looking at whether the sequence of which med you start first, whether it's going to produce better outcomes or not. And, delaying a few weeks just leads to a few extra events that you could have prevented, but compared to the historic drawn-out sequence, has remarkable benefits. But the absolute lowest event rate occurred with the simultaneous initiation. So here's mapping it out again on how this can be done, and very rapidly with sacubitril/valsartan, beta blocker, MRA, SGLT2 inhibitor, and the relative risk reduction in mortality that's expected with these therapies, and seen very early on with event curves diverging, even with the initial starting doses, but important to up-titrate as well tolerated. Now, you may be thinking that sounds well and good, but these medications can affect blood pressure. If I start them simultaneously, patients are going to get hypotensive, have big drops in blood pressure, will be on the floor. This is a ridiculous idea. But if you actually look carefully at the randomized clinical trials and real-world clinical experience, it is true if a patient has high blood pressure and you start an MRA, that blood pressure will fall. And same thing with beta blockers, same thing with sacubitril/valsartan, same thing with SGLT2 inhibitors. But if your blood pressure starts off normal or even on the low side on that 85 or 90 range, that the change in blood pressure is actually a millimeter or less. Or in the case of beta blockers, as heart function starts improving rapidly, blood pressure actually goes up and above placebo. So in fact, symptomatic hypotension is relatively infrequent. These drugs are well tolerated. There can be a little more symptomatic hypotension with sacubitril/valsartan, but that can be managed. So in general, well tolerated in the hospital or outpatient setting. And even when there is background therapy on board, or even when multiple drugs at the low recommended starting dose are being started simultaneously. The other thing I want to point out in this was a publication in JACC Heart Failure we put forward, where we looked, and it's a common experience. You start a drug, patient has a side effect, we attribute it to the drug. But we were interested, in clinical trials, you start the study drug, and it's either the active drug or placebo. Everybody's double-blinded, so, don't know. And so we looked how often in the trial that the clinician, the investigator, attributed this to a treatment-emergent adverse event. It didn't just happen, but they thought it was study drug doing this, and compared the rate between placebo versus our guideline-directed medical therapy. And what we found is, for the most part, very little difference, that as well tolerated as placebo. And when a treatment adverse event occurred, it often wasn't the treatment, was the underlying condition, or could have been one of the other meds the patients were on. So in fact, the absolute risk we're putting these patients on for serious adverse events is relatively low. So to not start or stop a mortality-reducing therapy off something that may not even have been a side effect of the medication really needs to be rethought about how we think about benefits and risks and the risk of omissions of these therapies. Now, you may be thinking, well, I've heard that some of these trials didn't really enroll frail patients, those that were older, comorbid condition. And that was true early on. But if you look at our newer trials, lots of comorbid condition, lots of enrollment above age 75. So how did those patients do? Well, in relative terms, their event reduction is every bit as large, and in absolute terms, because they're at higher risk, it's even higher. And the adverse events were similar and not at greater frequency in those older patients. And we have complementary data and real-world clinical effectiveness that is also the case. So our evidence base in older patients. So this concern about polypharmacy is misguided when it's mortality-reducing therapy. It's certainly reasonable when it's therapies that are on board that don't have a good reason for being applied in those patients or can interfere with their mortality-reducing meds. Well, do we really have data that supports that? So here's some real-world effectiveness data we've generated for beta blockers, sacubitril, valsartan, MRA, looking at patients where, their median ages are 77, 79, 80. There were individuals 90 and above, 95 and above being studied here. And treatment versus not treatment, we see the associated reduction mortality that very much rivals what we would expect from the randomized clinical trials, despite the very advanced age of the patients here. Now, what about renal function, right? If creatinine goes up by 0.3 milligrams per deciliter, what do we term that? Acute kidney injury. Who wants to cause acute kidney injury? And isn't that associated with worsening outcome? Well, these drugs impact intrarenal hemodynamics, but have no direct nephrotoxic effect. They're renally protective. They're indicated in chronic kidney disease. And in fact, you see curves like this. You start an SGLT2 inhibitor, GFR can drop, but then it really stabilizes or continues to progress in the placebo arm. And so long-term, you're preventing chronic kidney disease. Acutely, there wasn't injury to the kidney. There was just shifts in intrarenal hemodynamics. And overall, this was benefiting the patient. And here's direct evidence of this. Those patients in DAPA-HF that had an acute decline of GFR of greater than 10% actually had less cardiovascular hospitalization and death than those that didn't have the decline in GFR. So we're actually seeing this as a marker of success, marker of the drug working. Now, if you were on placebo and saw a decline in GFR because you got worsening your cardiac output or otherwise, or a nephrotoxin that was started, there really could be a problem and that was associated with worse outcome. But our sacubitril, valsartan, or MRA, our SGLT2 inhibitor, are renal protective, and beta blockers are renal neutral. So are there risks if we happen to discontinue a medication? Well intended, but saw the bump in creatinine, we'll stop it. What happens to outcome? Or heart rate seemed to go a little lower and, we didn't continue the beta blocker. We have, robust evidence generated now that withdrawal of these therapies and not restarting in the absence of an absolute contraindication is associated with a much higher mortality, in some cases perhaps even higher than having not treated in the first place, but clearly worse outcomes than having been continued or newly started on treatment. So there are harms about unjustified discontinuation of these therapies. So, can we bring this all together and show in a trial that you can start multiple meds simultaneously and intensely up-titrate and that patients could tolerate this and actually outcome improves? We now have that trial. This is STRONG-HF, looking at high-intensity care versus usual care of patients that were hospitalized with acute heart failure, who were not on or were on suboptimal dosing of standard heart failure therapies. This looked at triple therapy, not quadruple therapy, randomized them to two-arm. In hospital, early initiation of triple therapy, up titrating to be on at least 50% of target dose prior to hospital discharge, come back in week 1, week 2, and make further adjustments and try and by week 3 of post-discharge be on the full contingent at target dose of guideline-directed therapy for triple therapy, and then monitored for safety in 90-day, 180-day follow-up. Versus usual care, start what you want in the hospital, see the patient back as you'd like to, and make adjustments as seen. DSMB stopped this due to overwhelming benefit. And you can see this marked difference. Usual care, what happens? Didn't get started in the hospital, you were unlikely to subsequently be started in 90 days or 180 days, and your doses didn't change, and there was a big difference. High intensity care, did 100% get to target dose? No, but above 50%. And you saw, much higher uses. And if you look at half of target dose, you also have, above 80%. So how patients tolerate it? Heart rate, blood pressure, potassium. Yeah, there's some little differences here. eGFR, no real difference, but withdrawal or serious adverse events, largely comparable. Patients felt better, less congestion. New York Heart Class improved. The prognostic biomarker and terminal BNP dropped. What for clinical outcomes of heart failure, readmission, or all-cause mortality? A absolute risk reduction of 8.1%. That is huge, because this isn't treatment versus placebo. This is high-intensity care versus usual care. 34% relative risk reduction, highly significant. And importantly, quality of life improving substantially. So well-tolerated, more effective, improved adherence, more patients on target dosing, translating to better health status and translating to less events of existing therapy. So what are some tips of optimal titration of guideline-directed medical therapy? So close attention to volume status, diuretic dosing, checking orthostatic vital signs. If you've got orthostasis, adjust the diuretic dose, stagger the vasoactive meds, recognize the rising creatinine, decrease in GFR, totally expected or embraced or welcome, represent intrarenal hemodynamics. They are not acute kidney injury. These drugs are renal protective. Attempt to distinguish symptoms that represent the underlying heart failure and comorbidities and actual medication side effects, and work through and treat through those, because often you'll stabilize, improve heart failure. Those will resolve as a result of the guideline-directed medical therapy. Critically important to emphasize to patients the benefits of med adherence, address any cost or access barriers, but really important conceptually, whereas most patients, especially when therapy is drawn out, that with each additional medication, they think it's an indicator and a sign that they're getting worse, or prior therapy, the early drugs started, were not working. And so they had to add this therapy. And why am I getting worse? And this is the sign. And my goal is to get off the medication, rather than viewing this is the complete package that is going to markedly improve my survival. And is the marker and the true meaning of benefit in the process by which I can judge if I am being adequately treated. So with that, we really need a change in mindset where there's overly focused of, I don't want to prescribe this therapy or adjust dose because the patient may have side effects or adverse events. So those potential harms are going to lead me to defer to some other time to eventually get around to it, as opposed to recognizing the potential harms of not trying to start the new indicated therapy or adjust dose, where patients we know from trials will have decreased survival, increased hospitalization, decreased quality of life, and increased symptoms. So every visit and every setting is an opportunity to initiate or escalate guideline-directed medical therapy unless that patient's on full maximal well-tolerated therapy of all foundational therapies. So new onset heart failure patient, not low risk, they need aggressive intensive treatment. Stable outpatient heart failure patient, not low risk, need this aggressive treatment. Hospitalized heart failure, not low risk, need to fear the risk of omission and manage around the risk of commission. So this slide highlights the magnitude of benefit here in these settings of the lack of initiation, titration, or persistence of these key therapies are. And to really highlight this, we now have data for heart failure with EFs 40% or above for SGLT2 inhibitors. So delaying or omitting GDMT in eligible patients with heart failure are associated with these preventable deaths and hospitalization. We can overcome that by prescribing and optimally titrating these meds, using them together, starting as early as possible, and really get optimal outcomes. This slide just further highlights the cumulative benefits for mortality, but I also want to emphasize it's an 85% relative risk reduction in heart failure hospitalizations, a 33% absolute risk reduction. These are large and profound benefits. So the guidelines have embraced this approach with regards to focus on the mortality reducing therapies. Here are the ESC guidelines I showed you previously, the management pathway. So you can see that this emphasis on the key mortality reducing quadruple therapy. Here's the 2022 guidelines from the AHA, ACC, HFSA. Each of these therapies, class 1 recommended, each of them level of evidence A to be used together in combination in these eligible patients in the absence of contraindication. Yes, there are additional heart failure therapies, but they're down at the 2A or 2B level, can be thought about for select patients, but the main focus initially should be on the initiation and intensification and optimization of the foundational mortality reducing therapies. I want to further highlight this issue, though, of why it's so critically important to get therapy started prior to hospital discharge. Here's Connect-HF. You had a huge number of participating practices, large, well-powered trial to try and improve outcome, focused from the time of hospital discharge to 12 months of outpatient follow-up, disseminated the guidelines, evidence, provided feedback, and all of those components. But in the outpatient setting here, and what we found is the net median change of use and dosing of GDMT in the absence of contraindications or intolerance was nil, was zero, did not change. And of course, outcomes didn't change because therapy didn't change. And so we really need to recognize hospitalization is a teachable moment. If we have a patient discharge, it is very hard to ensure outside of a highly specialized heart failure clinic they're going to be initiated. But even if they are, that delay of a few days or weeks, they may have had an event that could have been prevented within the hospital initiation. So the wealth of our data shows us in-hospital initiation has a wealth of benefits, and there's no advantage to delaying therapy to outpatient. And unfortunately, in heart failure, going slow means not safer, not more effective, not more patients treated, but in fact, rarely initiated, rarely titrated, and a lot of preventable events. And globally, in the US and worldwide, it's meant that outcomes have not improved in the way that they should have based on the evidence-based therapies we have. We have to go fast, have to go intensive for appropriate patients and with appropriate monitoring. So what do the guidelines say about GDMT during hospitalization? A class 1 recommendation for initiation optimization during that hospitalization is critically important. And again, focused on the quadruple foundational GDMT. So I've focused on starting off 4 classes of meds at diagnosis and hospital initiation, but what else can help us in these goals? And so there's evidence to support performance improvement systems. I'll cover a few of those. Multidisciplinary heart failure disease management programs work. Have dedicated navigators or pharmacists that are totally focused on actually nothing but initiating and titrating GDMT. Have clinics that are dedicated to this. Do it via telehealth. Use digital tools, health apps, reminders, or in fact, go directly to the patient. Tell them what meds they actually need to be on by interactive videos. Have them go into the physician visit, prime for that, and ask for the meds, and that actually improved care in EPIC-HF. So here's data from Get With The Guidelines. These are actually hundreds of hospitals, tens of thousands of clinicians, and we've been able to sustain over 15 years a high level of performance for these key evidence-based therapies. Why we want it to be 100% for each of the performance metrics, well over 90% on average here, in the composite care improving markedly and being able to maintain this over time. In the outpatient setting, improve HF, not just medications, but even indicated device therapy, we're able to get meaningful improvements. And even for therapies like beta blockers, starting out pretty high, like, wow, 83%, be happy, we're able to get that up even higher with this type of a program. So systems approach can really make a meaningful impact of getting the data, feeding back to clinicians, but where they're empowered to actually make a meaningful difference and understand how to use the therapies and who is eligible. This was data using electronic health record nudges for GDMT and prompt HF. There was a modest impact here, but this is scalable across the country. So even these type of changes on a national level would make a meaningful change. So here they gave tailored alerts to the clinician and would call up the order, and you could see, oh, here's the EF, here's renal function, they're eligible for the med, and could start that med very quickly. So we can scale this up even further. Here, however, is an approach where we highlighted not just getting on quadruple guideline-directed medical therapy, but time matters, and that within 30 days, you've got to be there, and got through the AHA, implement HF, 78 sites. This is, thousands of patients here that are being looked at. And what we then did was, here's the focus. In hospital, get quadruple therapy started. Sure, it's preserved and maintained and titrated over the first 30 days. And you can see this preliminary data background, 14% of discharge, 9% at 30-day follow-up of quadruple therapy measure, increasing just in 2 quarters to 49%, 55% at 30 days. So we saw, from a relative and absolute standpoint, these are huge, unprecedented types of increases. But ideally, we want this fully implemented, 100% of eligible patients. But you can get this very rapid effect if focused and see this as so essential to the quality of care and outcomes. We now have some therapies in heart failure, mildly reduced preserved EF, SGLT2 inhibitors in particular. They have a class 2A recommendation. We can see there's a continuum here. So for those patients, we really do want to be thinking about, double, triple therapy. Here's the indications by EF. So with that, as we really think about our 4 pillars of survival-enhancing medications, I hope you've been convinced as far as the magnitude of benefit and their approaches to get them started. But, what about value and cost? Certainly, beta blockers, MRA, $40 a year, that's not a problem. But sacubitril, valsartan, SGLT2 inhibitors, they're banded drugs. That's more expensive. Are they cost effective? Well, by formal cost effective analysis, they absolutely are. But, is it still worth the out-of-pocket cost for patients? Is it worth the time and effort to navigate access? So we're really interested about, well, what's the cost effectiveness of quadruple therapy, all 4 meds together? And turns out, because of these additive benefits, it falls into the high value category. And so we recently published this in JACC Heart Failure. And then we asked, well, okay, with that, what about the intensive therapy and initiate them early, even though you had to have those extra visits, have the nurses involved, cost of the medications, and found the cost per quality adjusted year life saved, was less than $10,000. So ultra high value. And so, in every care setting, from an economic standpoint, this intensifies GDMT really makes sense. I do want to highlight here, though, this interesting difference between cancer, because a new drug comes along that's IV, extends median survival by 3 months, even though there may be really bad side effects, and the cost is $250,000 a year in oncology. It's a breakthrough therapy, ingenious, embrace clinically rapid, widespread practice. No system needed, it's done. Heart failure, we get a new oral convenient therapy, extends median survival by 1.3 years, well-tolerated, serious adverse events less than placebo, costs $6,000 a year, and the perception, too expensive, not sure it's really worth the benefit, why bother? And we see minimal uptake in clinical practice. There's just, completely distorted perceptions of therapeutic value, cost effectiveness across these disciplines that we need to understand better and overcome within cardiology and heart failure. So to kind of bring this together, what is the magnitude of benefit of doing what most patients with heart failure are currently on, ACE inhibitor, ARB, and beta blocker, and leaving the status quo, versus ensuring they're on sacubitril, valsartan, MRA, and SGLT2 inhibitor along with the beta blocker? And we projected those survival gains. You can see it in relative terms, but we can extend patients' life, not compared to no therapy, but compared to double therapy, Quadruple therapy extends median survival by 6.3 years. I think it's really hard to argue that it's not worth that effort in each and every patient to achieve this. And we have evidence in real-world practice that as we translate the guidelines into practice, we can get every bit as large of these mortality reductions. In clinical trials, we see that over time, the outcomes of those in the placebo arm have improved markedly. Why is that? Because by protocol, they've got to be on guideline-directed medical therapy to get the new study drug as background therapy. In the same time frame, in clinical practice, what have we seen? Very little improvement in outcome for heart failure reduced EF. Why? Because there is no protocol requiring that you must do this in the clinical setting. We need to get to that kind of mentality where we view that as kind of the core-based therapies we apply, and that it's as essential as we do in our background protocol in clinical trials to apply in clinical practice. So the cumulative benefits are very large here. The relative risk reductions, the absolute risk reductions, the NNT, I'll make a compelling case. Yes, I recognize a 9.5% 2-year mortality risk is still too high. We need further research. Not every patient can tolerate each of these therapies. We need further research. But with these therapies, if we could optimally apply them, we could have phenomenal impact. So here's the population benefit with guideline-directed medical therapy optimally deployed. 100,000 additional lives can be saved. So to summarize, the approach to heart failure reduced EF medications benefits are additive or incremental, no substantial overlap. Optimal approach is to use each medication, demonstrate a reduced mortality in combination, so long as not contraindicated or not tolerated. Start each without delay. Serial selective approach, it doesn't work well and leads to preventable events. There's high economic and clinical value, and implementation needs to improve in all clinical settings. Thank you so much for your attention, and welcome any questions that you have. Thanks so much.
Awesome. Thank you so much, Dr. Fonarow. I'll just remind folks that if folks do have any questions, they're welcome to be submitting them through the chat. It looks like the question that we have had thus far, Dr. Fonarow, is around the physiology that each of these drugs are, or the seemingly like the mechanism by which they are achieving these clinical outcomes. I wonder if you could comment on that.
Yeah, and I appreciate this question. And a simple answer could be, you know what? Even if we think we know what they are, it doesn't matter because they actually work and they've been proven to be additive. But that's not totally satisfactory. We'd like to know the mechanism. We'd like to know that they're not entirely redundant. So neurohormonal inhibition plays a major role in the pathophysiology of heart failure. So the renin-angiotensin-aldosterone system, sympathetic nervous system. So that's traditionally how we viewed these drugs. They also have anti-inflammatory properties. They alter gene expression. But so our ACE inhibitors and ARBs are blocking the angiotensin II formation or at the receptor. MRAs are blocking aldosterone at the MRA receptor, and they have a cascade of pathologic remodeling. Beta blockers block apoptosis and the sympathetic activation that's pathologic to the cells of the heart and the vasculature and promote reverse remodeling. So that's beta blockers. Neprilysin inhibition releases these beneficial neuropeptides that aren't broken down. So natriuretic peptides aren't broken down, adrenomedullin and others, its beneficial effect. SGLT2 inhibitors, super interesting. It may be autophagy, it may be improved mitochondrial function, it may be a whole variety of different effects. So that is still being worked on, but they clearly work as renal and cardiac protective. They work in heart failure and preserve reduced ejection fraction, but importantly, reduced EF, they are a life-prolonging therapy. And so these therapies don't overlap. They're truly additive incremental by the physiologic mechanisms, and they work in a way that translates to this mortality reduction that's additive. And when we apply it to patients in those tested target doses, it translates to that benefit that we've actually seen here. So understanding the mechanism is helpful in understanding the principles, but in the day-to-day, the management of that patient, understanding those target doses, what the side effects are to monitor for, how to work around them, and the importance of adherence is really what's so critical.
Can I use my prerogative here and just ask one question of what do you think is going to be next? Do you think semaglutide is going to pan out in a HFrEF population?
Yeah, so remarkable data with regards to the GLP-1 receptor antagonist for individuals that have obesity. We've now seen with ASCVD less cardiovascular death, less heart failure. We've seen in heart failure preserved EF improvement in functional status. So that's clearly quality of life's important. Whether that will translate to mortality reduction in heart failure remains to be seen, but improving quality of life is important. And like 40 to 50% of our heart failure patients fall in the obese category, another third into the overweight category. And so, there are a large proportion of patients we really think can benefit. There will be additional data coming out presented at ACC. So very well may be important there. But I do also want to highlight obesity is such a risk factor for developing heart failure. So preventing that heart failure in the first place, these are incredibly important drugs. And so, in a way, can also highlight preventing heart failure in the first place is truly the best treatment. So if we better implement our hypertension treatment, lipid management, and otherwise, and prevent heart failure, that's great. But once heart failure develops, truly need to optimize this quadruple therapy. Given all of the different mechanisms that play in the pathophysiology, it's naive, quite frankly, to think one or two meds is enough. That we need that four corners of our therapy to build that cage around heart failure. So quadruple therapy, actually from a physiologic basis of multiple overlapping mechanisms, actually make a lot of sense. And then managing selectively these comorbid conditions like obesity, like atrial fibrillation, like the coronary disease that these patients have to further refine their therapy.
Awesome. Thank you. I do see that it is 1:01, and I see that folks are having to start dropping off. So Dr. Prutkin, unless you have other questions or comments to make, I think we'll wrap things up here. And thank you so much, Dr. Fonarow, for joining us today and for that fantastic presentation. And as a reminder to folks, we will not be having a Department of Medicine Grand Rounds on the third Friday of this month, but we'll look forward to seeing everybody back in March.